We're going to start with our panel. Okay. So our final presenter this morning is Ken Dodge, who is the William McDougall Professor of Public Policy and Psychology and Neuroscience at Duke University, where he also directs the Center for Children and Family Policy. Ken, who is a clinical psychologist by training, has written over a vast number of issues on child development and all aspects of development, and could speak to us about many of them. But we have particularly asked him to come here because he has taken his work and his interest in violence in children and how to prevent problem behaviors, and taken it to a community level in developing a number of programs, and particularly in developing Durham Connects, which is a universal home visiting and parent support program in the Durham area. And he will be talking to us about that aspect of his work on taking programs to scale.
Thank you, Michael. And thank you to the committee. I really appreciate the opportunity and invitation to be with you. I'm excited about this work. I understand that I've been asked to talk about implementing evidence-based parenting programs at scale to achieve population impact. And I have added the tagline, a social engineering challenge, because I think about it as an engineering problem. And some of my favorite colleagues these days at Duke are my colleagues in the School of Engineering. Systems engineers, Guillermo Shapiro, Robert Calderbank, Larry Carr, and folks like that who think about systems and how to engineer a system and how moving parts interrelate. I understand I have a couple of challenges that I've been asked to address in bringing some programs to scale to have population impact. One is how do you implement programs on the ground, at scale, with real families in the real world? And number two, how do you design and implement a system that's addressing the universal population, but at the same time recognizing everything that's been said this morning, which is about the diversity of needs and of cultures and of backgrounds and of parents? Can one program, one size cannot fit all. So how do you do that? The Institute of Medicine, in its wisdom, has a model for addressing this problem. Back in 1994, a panel probably not unlike this one developed what's called the Preventive Intervention Research Cycle. And this is just taken from that report. And this might be familiar, but the idea is to start with a problem and an analysis in the laboratory, in the university, in the pristine circumstances of that university, and try to understand the problem of parenting in this case. And then also in the laboratory, develop an intervention, culture something. I mean in the, in the laboratory culture sense, in stark ironic contrast to the community culture, but in the laboratory, culture and intervention, develop it. Use a small randomized controlled trial with 50 parents who are pre-selected and see if it works. And then move it to the community and see how you have to tweak it in what we call an effectiveness trial, and then move it to scaling it up. Right? That's the Institute of Medicine model. There is a feedback loop, but most of the movement is left to right. There's a lot of support for parts of this model. Mark gave a terrific presentation this morning about the scientific evidence for the importance of high-quality parenting in the early years. The only one line I'd like you to look at is, humans are among the most helpless species at birth, and I would dare say the most helpless species at birth by evolution, right? Most species can survive without their parents. Human beings cannot, whether it's for nutrition, but also emotional security, social connection, social thing. Infants will not survive. It's the obviousness of parenting. I'm not talking about individual differences in parenting. I'm talking about as a species. There's also a lot of replicated evidence about the technology of parenting interventions. You know, we have parenting interventions that have efficacy trials with a great deal of support, whether it's early parenting support by home visiting, nurse-family partnership, healthy families, early parent training, Mary Dozier's terrific work on attachment and biobehavioral catch-up, parent supports in the context of child care programs like the Perry Preschool, Abecedarian. We've got these parent training for early or toddler conduct problems, Rex Forehand, Jerry Patterson, Patty Chamberlain in a couple of years. But we've got these technology, and we have done some scaling up. Head Start, early Head Start, had their vision background in the early training project and in early laboratory kinds of studies. Those are somewhat scaled up. McV is now one version of trying to implement in a large-scale way, nurse-family partnership and other programs. But I dare say no program has ever been, in parenting, has ever been scaled up to achieve population impact. The model has not yet worked. Right? The Institute of Medicine model of this left-to-right movement has not yet succeeded to achieve population impact. Why? A lot of reasons. The developers of parenting intervention programs really intend to have population impact at the outset, right? It's shown in the selection bias of who participates, right? So for a nurse-family partnership, to participate in one of those 3 trials, you were a paid volunteer. You had to agree that you were not going to move out of the community for 2.5 years, right? And you were going to participate, right? That's a selective group. The heterogeneity of the population needs suggests that the population impact cannot occur with any one program. Parents have trouble parenting for a heterogeneous set of reasons. Some are parenting skill deficits, but good golly, some are for stressors, financial or other. Some are for mental health impairments, whether it's substance abuse or depression or whatever. Some of it is because of all these culture variations that we talked about this morning and that nice session just preceding it. It turns out when you try to scale up programs, there are selection biases in who participates in scaled up programs. The high-risk families tend to want to participate more, but drop out at much higher rates and are not able to complete programs. When scaling up, penetration and retention is relatively low, 35 to 50% by a review by David Olds. Why? Stigma, they're hard to reach, all that mobility. If you do implement, there's a degradation of intervention fidelity and quality that typically occurs. David Olds calls it the scale-up penalty of 50%, he says. And finally, and I think this is really maybe the most important one of all, that bottom 2 lines. We overestimate the community capacity to meet the needs of the full population. So a lot of our parenting intervention programs are not only parenting interventions in the home or in that session, but we're teaching parents or encouraging parents to connect to the community and to take advantage of community supports and resources. NFP and one earlier version of my own parenting intervention program, right, where if we're going to intervene with 50 families, we try to give our parents a competitive edge. We try to get them to be first in line to get the highest quality child care, right? Or how to break through the morass of the social service system to get that emergency loan that you are entitled to, right? That's what we do. Well, imagine trying to do that with everybody. Not everybody cannot be first in line, right? We have to somehow change the community resources, either increase it or realign it. And our parenting interventions, when they move from the laboratory to the community, haven't taken that into account. All right, so what we need instead is, I think, a public health model or public policy model. We need to start at scale, and I thank Michael Wald for that term from a terrific paper that he has written, and he said it earlier this morning. We need to start at scale. So the major challenge is how to deliver a universal system to meet those diverse needs. I do think we have some positive examples, not in parenting, but elsewhere in our service system. Think about it. Schooling, K-12 schooling. It's a universal system. It meets diverse needs through a combination of a universal curriculum plus individualized needs. We call it special education, other kinds of programs. More or less works, but at least it's got that design. Here's a couple more that do work, probably better than our schooling. Dentistry, it's a terrific system. It may be a public health model that we should all emulate, right? We have fluoride in the water. That's universal. We have daily brushing of teeth. We have checkups with your dentist. And then for those who need it, we give them braces, and we spend an awful lot of money, right? But that's an individualized approach with a universal problem. We do it in healthcare delivery, right? I live with a physician, right? So we have models of our pediatricians and our family practitioners, right? They universally see children in at least an annual checkup. What do? That's universal delivery. They assess universally. They do some interventions universally, right? My 5-year-old at one point was told to, buckle her seatbelt and wear a helmet when riding a bike, and those are universal interventions. But there is also triaging and individualization, sometimes with short-term interventions by the pediatrician and sometimes referral to tertiary care, right? It's a model that works. We do have some population models in the psychosocial arena I won't talk much about, but refer you to Communities That Care, Triple P, Family Checkup by Tom DeShawn, that sort of thing. So the challenges are to do two things at once. One is a top-down infrastructure that I would call a preventive system of care, where we align community resources. In Durham, North Carolina, where we work, we have a computer data bank of over 400 community agencies that serve families birth to age 5. Right? So we're trying to align them. And we have a system then to reach and screen all families. That's top down. Bottom up is the importance of those individualized parenting interventions. They are truly, truly important, and the wisdom we've learned from that. We assess and we identify unique risks and needs. We develop short-term interventions that connect families with the community. So it takes both kinds of approaches. So because I'm so excited about it, I do want to tell you about the Durham Connects model, at least a little bit. We began 2001, funding generously by the Duke Endowment. Initially, we called it Durham Family Initiative, and they asked us to try to achieve a population impact on the community rates of child abuse. We had some encouraging early findings. We wanted to do a couple of things. Move to early life interventions to align the community and work with the whole community, so we have a series of memoranda of agreement. We wanted to manualize the intervention so that we can replicate it to other communities and subject it to randomized controlled trials. So when we think at the community, we have to think in innovative ways about randomized trials as well. All right, the basis of this Durham Connects idea is 3 steps. We have to connect with the family, every family in the community. So we do that at birth in the birthing hospitals. We invite ourselves into the home through a visit with the public health nurse. We tell them we're going to bring some diapers and all kinds of goodies. We try to get into the home. When we're in the home, we screen. We assess risk in healthcare. Do they have a medical home? Are they going? This is at 3 weeks of age, right? We assess financial stability. Do they need an emergency loan? What's their Medicaid status? Can we get their baby signed up for Medicaid even if the mother is an undocumented member of our community and not eligible, right? Child care. What are their child care plans? Parent mental health, substance abuse, domestic violence, depression. So it's a pretty broad kinds of screening. We quantify the risk. And number 2, we connect the family with the community. We do short-term interventions with them, but then we connect them with the family, with the community as needed. Professional community, as I said, with this data bank of 400 community agencies. So that number 3, the goal here is still firmly grounded in helping parents connect with their infant. Right? It's not a replacement of parenting, it's a parenting support so that parents can connect with their own infant. All right. We spent a decade trying to set this up in the community of Durham before we subjected it to a randomized controlled trial. But we did it by randomly assigning every birth in the Durham community over an 18-month period, 4,780 births. We recruited even-numbered birth date births into the intervention. Odd-numbered birth date births were the controls. We had no contact with the controls. They didn't even know they're in a study, which is another part of getting 100% participation, because you can use administrative data, right? And we can compare even birth date administrative records with odd birth date administrative records in an ethical, IRB approvable way. And then our challenge is to try to have an impact on every even birth date birth. We analyze by intent to treat using administrative record reviews, and then with a random sample of all of them, we do more interview kinds of things that would please the developmental psychologists in the group about observing parent-infant interaction, that sort of thing. We could implement the program. 80% of the families agreed. 86% of those who agreed completed the program. Fidelity was pretty good. We had an independent rater watch our nurse do our home visits and interventions, and they had pretty good compliance. Briefly tell you about how we scored risk. Each of 12 different risk factors gets scored by the nurse in the home on a 4-point scale. 1's no risk, 2's minor risk that the nurse is going to change and intervene with. 3 is considerable risk. Let's get a community referral. 4 is imminent risk, emergency. Thank goodness, very, very low base rate, but that's when you call 911. 45% of all the families in Durham score at least 1-3, meaning they have considerable risk in one of those areas where we wanted a community referral. 39% of all the families we connected and actually got community services. So 39% of all of the births in Durham ultimately got a community service intervention. All right. We had some positive impacts. Very briefly, I'll go through. Mother-reported positive parenting behaviors are better in the even birth date families than the odd birth date families. Blinded observers rate mother parenting quality better. No impact on whether babies are more or less likely to be in out-of-home child care at age 6 months. But if they are in out-of-home child care, it's of higher quality. Better mother-rated father-infant relationships, better observer-rated home safety, lower probability of mother clinical anxiety. But here's the most important part. What happens in dollars? Emergency medical costs, right? So we use administrative records to look emergency room visits, overnights in the hospital, in the Durham community, coded by odd birth dates and even birth dates up through age 12 months. The red line is the controlled families. You can see it, hard to see there a little bit, but it does just keep increasing. The yellow line are those even birth date families. Not that they received the intervention, but they were randomly assigned to receive the intervention. And a couple of things to note. We have a positive impact right away. It's sustained through the first 6 months, but we also have a preventive impact. In the second 6 months, there's a new intervention impact that's 31% more reduction. So it has this ongoing preventive positive impact. That's pretty impressive. Well, next question is, so does it work for all different kinds of groups? So we spent a lot of time on this. By birth records, we can code high and low risk based on birth weight and other factors. The left side there is the impact, the red bar of the control, the yellow bar of the intervention. Positive impact on low risk, also positive impact even higher on high risk. We have positive impact for both groups of insurance. On the left is if you have private insurance. On the right is if you have Medicaid or no insurance. Again, positive impacts for both kinds of groups. And then also by ethnicity. Majority ethnicity is on the left. There's a positive effect size. On the right are minority. And there's a positive effect size there as well. So it works with a bunch of different groups. Briefly, the benefit cost analysis that I'm not going to bore you with, but the most important points are the program was delivered at about $700 a family, right, community-wide, $700 a family. And we calculate the emergency care costs from the actual records, right, from the actual hospital records of how much they charged and billed, right, for emergency visits, for a hospital, like that sort of thing. And it turns out that there's a return on investment of $3.44 for every dollar invested in the program by 12 months. That's not a very long follow-up. All right, so in Durham, emergency care costs for infants for a year without Durham Connects is about $10 million a year, a little over 3,000 births. Durham Connects is about 2.2 million, so it's going to save over $7.5 million in 1 year. Seems like a no-brainer, so why isn't it being implemented by government dollars, or could it be, or should it be? So the second to the last slide, and second to the last point that I want to make, is how we need creative financing for our parenting interventions. And to make 2 points. One is we have to figure out barriers to government payment. So I spent a lot of time talking with directors of Medicaid, and why won't they pay for this kind of program? And some of them are very excited about it, would like to, but there are two factors. One is it's risky. If it doesn't work, they're paying for the program up front, and then they also have to pay for those medical care costs at the back end. So it's still risky. And number two, they just don't have upfront capital all the time. Their budgets don't allow this prepayment, right? Government services don't always work that way. It's a fee-for-service after-the-fact kind of system. But there are solutions to that. Those two things, risk and upfront capital, that's what Wall Street's all about. That's what venture capital is all about. So the whole idea of social impact bonds, pay for success, private investors is proliferating across the country now. Started in the United Kingdom, went to New York City, went to Utah, went to South Carolina. Goldman Sachs has a $250 million fund for this kind of purpose. So that's one way to go. Another way to go is, you know, I look at it and say our social service system spends an awful lot of money already. It just is not spending it in ways that are consistent with the science. And if there's one thing that I would change in this country, it's to get our social service system payments aligned with our research system. Right? It just doesn't happen. ACF, SAMHSA, federal governments, federal systems are barred from doing research. And the research system has so little money that it can't do the kinds of research that are required by what I'm talking about, which is really my last slide here. We need place-based randomized trials. So Durham is a unit of one. We need to randomly assign communities, right, to see if these engineered systems work or not. That's a lot of money to put forward, but I think that's what we need. And I borrowed that from Larry Yaber, who's really kind of a guru about place-based intervention. Number two, we need to find effective parenting interventions that market well, non-stigmatizing, non-threatening, with deep penetration. I love the ideas that my colleague Candace Odgers are putting out about push-out kinds of interventions. You know, we're still in an era, I think it'll pass, but right now we're still in an era when if a mother receives a text from her pediatrician, she will read it. Right? From all backgrounds, she will read it. Right? I think 5 years from now that we're going to throw those away like we throw away, you know, unsolicited other kinds of things. But we as a community, we still read text. So push out text or maybe a way. Creating systems of infrastructure at the population level, right? So how do we engineer these systems? We need to research that. 4, we need to understand the benefits, costs, and the financing to a much greater degree than I know. And finally, we need to understand policy and politics through framing, right? How do we frame all of this? And my favorite case study from history is the history of American public education. How did we pull this off? That we have universal public education. Starting in the early 1800s, by 1900, virtually every child was enrolled in free, compulsory, universal education for 12 years. Right? Certainly we can do something similar, birth to age 5, for parenting and child development. So let me stop there and see what you all have to say.